Hello everyone, I am Dr. Park, an obstetrician and gynecologist. Continuing from our last session, today we will briefly look at several conditions closely related to preterm labor. First, let's discuss cervical insufficiency. This condition occurs when the cervix begins to open silently and without labor around the mid-second trimester, approximately 14 weeks into pregnancy, leading to preterm birth before 28 weeks. The exact cause is unclear, but it can be associated with a history of cervical conidation, a procedure often performed when cervical cancer is suspected. Because symptoms are usually minimal or absent, it often goes unnoticed until it is detected urgently. Typically, careful observation based on medical history helps in diagnosis, and treatment involves a surgical procedure called surgical cerclage to stitch the cervix closed. As preterm labor progresses, the cervix shortens and begins to open. At 24 weeks of pregnancy, the average cervical length is about 35 millimeters. However, as it shortens, it typically changes into a funnel shape. For high-risk pregnancies, measuring the cervical length via ultrasound can be helpful in predicting preterm labor. This is the typical funnel-shaped cervix. You can see that it has shortened to less than 2.5 centimeters. This is the cervix, and this shape changes into the funnel shape. It shortened. This surgery is performed if a woman has had 3 or more mid-trimester miscarriage or preterm birth. It is also done if the cervical length is less than 25 millimeters and there is a history of preterm birth or mid-trimester miscarriage. However, the surgery should not be performed if the following cases: if there is suspected intrauterine infection, ruptured membranes, uterine contractions, or vaginal bleeding. It is also contraindicated if the fetus has died in uterus or if there are suspected fetal anomaly. Of course, before surgery, the following checks must be done to differentiate between indications and contraindications. An ultrasound should be performed to confirm fetal viability and check for anomalies. And a culture test should be done at the cervical entrance to check for infections. There are different types of cerclage surgeries. The McDonald procedure is common, and if it fails, the Shirodka procedure may be used. If these are not successful, an abdominal cerclage can be performed, which involves entering the abdominal cavity to stitch the cervical isthmus. The isthmus is the area between the body of the uterus and the cervix. It is sufficient to be familiar with these names. After surgery, complications may include intrauterine infection, rupture of membranes, preterm labor, and lacerations of the cervix or uterus. Next, let's discuss chorioamnionitis, which is also closely related to preterm birth. Chorioamnionitis is an infection that occurs in the chorion and amnion, the membranes surrounding the fetus and amniotic fluid during pregnancy. It is typically caused by a bacterial infection. This condition can develop if a maternal vaginal infection spreads, if there is prolonged rupture of membranes for more than 12 hours, or after invasive procedures like amniocentesis. Symptoms include a fever higher than 38 degrees Celsius, tachycardia in the mother or fetus, and foul-smelling vaginal discharge. The most reliable diagnostic criterion is an elevated body temperature. There are no definitive tests during pregnancy, so if clinical symptoms suggest chorioamnionitis, immediate delivery and antibiotic treatment are required. Finally, let's discuss preterm premature rupture of membranes. Preterm premature rupture of membranes (PPROM) occurs when the amniotic sac breaks before labor begins, particularly before 37 weeks of pregnancy. This can lead to dangerous situations such as cord prolapse, intrauterine infection, and preterm labor, so it's crucial to go to the hospital immediately. Symptoms include a warm, warm watery discharge. To confirm PPRM, a sterile speculum is used to check for pooling fluid, and a nitrogen test is performed to test the pH of the fluid. Amniotic fluid has a pH of 7.0 to 7.5, while vaginal discharge has a pH of 4.5 to 5.5. An ultrasound is used to check the amount of amniotic fluid and the condition of the fetus. A digital examination should be avoided. If the membranes rupture early, it can lead to complications such as fetal infection, placental abruption, cord prolapse, impaired fetal lung development, or neonatal respiratory distress syndrome. After the membranes rupture, labor usually begins, and in more than 90% of cases, delivery occurs within 48 hours. For pregnancies between 24 weeks and 33 weeks and 6 days, the treatment involves administering prophylactic antibiotics, giving steroids to promote fetal lung maturity, and using tocilizumab to suppress uterine contractions. After 34 weeks, the focus shifted to attempting delivery, which may involve a cesarean section if necessary. Antibiotics are also administered to prevent infections. Today, I have provided a brief introduction to conditions closely related to preterm birth. In the next section, I will explain the process of successfully managing the risks of preterm birth and achieving a successful natural delivery.